Okay,
So we
sir.
shall start with the webinar now of the Imaging Sciences Committee.
Okay.
Yeah.
आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
So on behalf of the President, Dr. Durgadas Sasrana, and the entire EC team, and we welcome you all to this webinar by the Imaging Committee of KSOGA, by none other than the chairperson, the very enterprising young man, Dr. Raju Giredi. And he has brought us yet another episode of wonderful learning, and that is on Mullerian anomalies. And today I think he will build a bridge between the imaging of such anomalies and the clinical aspects of it. So all the very best to you, Raju, and I can see that you have great faculty also. So I shall now hand over to Dr. Durgadas to say a few words, and then we can begin the session. Thank you.
Thank you. Thank you so much, ma'am. Thank you so much.
Good evening to the family of KSOGA. As we all know, everybody is excited about this webinar. There are so many webinars of KSOGA, and we all know Raju Giredi's webinar always catches lots of delegates. He is not only a good teacher, he's a good scientist, I can say. He does the research, he does the work on his own, and he presents to the delegates. And the topic he has chosen, it is the incidence is increasing, probably because of the increase. The quality of the imaging has been improved a lot. That may be the one of the reasons. Second thing, infertility people, those who are coming to the forefront nowadays and getting ultrasound scan, or patients with recurrent pregnancy loss, they are the ones who are catching the doctors, gynecologists' attention, and probably that may be another reason to have the increasing incidence of Mullerian anomalies. And this is one of the very important topic every gynecologist should know about. Without wasting any time, all the best, Dr. Raju. We all are very eager to listen to you. Thank you.
Sir, namaste. Sir, namaste, sir. Sir, thank you so much, sir, for this kind introduction and your blessings always. Thank you, Shobha ma'am, for being always there to guide us. I'm really very grateful to Durgadas sir, because this is his first presence here in our third webinar series from our Committee of Imaging Sciences. Thank you, sir, for being out there. But in all rest too, though we have missed, your blessings are always there. We have done good work, and we'll try to do good ones, sir. And seeking blessings from our patrons and all the KSOGA members, the secretaries and the treasurers, and all the EC members. I take upon this opportunity to welcome you all for our third webinar on the imaging aspects from the Imaging Committee Sciences. So as we all know that we will be doing every Thursday, that the last Thursday, we have chosen to do one webinar. One will be on gynec and one will be in obstetrics. So we have done with one gynec and obs, and so we'll be pushing to gynec again. I have chosen this topic. Why? Because just not to discuss embryology, but this is one entity where we will try to know about how the morphological changes are seen in the uteruses. And as sir has rightly pointed out, One is the imaging. Next is the incidence of so much of infertility or subfertility issues that we are encountering. That is one of the reasons that we are seeing so many cases of Mullerian anomalies, because we are screening every lady. As what Sir rightly told, if we see 10 OPDs today in our practice, we are seeing at least 6 to 7 of them for subfertility issues. So the rest 3 might be pregnant ladies for ANCs. So I would like to thank my boss, Dr. Jayaprakash Patil sir, for without his guidance and wisdom, I would not have been here for my imaging. I joined under sir to hold the scope, but now I'm holding my probe. But this is how we go in understanding our clinical aspects with imaging purposes. So I will try to share my screen first. So why I have modified a bit little because I want to keep it more imaging perspective. So it is on diagnostic utility of 2D and 3D. We all are doing our scans. A majority of us are doing our scans, especially we all have a small scan machine within our OPD premises and all. And most of us are well versed with doing gynec scans, but we shall try to see how we should not, how meticulously we can really bring out the Mullerian pathologies if at all we see. I bring greetings from our society, that is KSOGA, and the place I work, the Betadur Hospital, Raichur. And thank you once again for everybody joining here today. So in the last class, in the first webinar, last class, we saw how to optimize the image and how to do a systemic transvaginal sonography. Yet again, I want to recapitulate that because this plays a very important role in understanding how we should do our TVS so that we are not going to miss the pathologies inside. Why am I choosing TVS as the prime aspect here again? As what sir told and I wanted to share that also, that because of subfertility issues being on higher rise, and everybody are definitely not contraindicated for doing TVS in such age group, and TVS being the most common best utility that we can have today. Yes, I do agree Mullerian anomalies are also common in younger age group, but definitely they will present with enough complaints. Either it is primary amenorrhea or severe dysmenorrhea. Such cases we'll also try to see some few examples, but we'll touch upon the most common ones, and we are seeing these entities every day, every now and then. But are we right in diagnosing them? So we shall try to see the most common entity today. I will be slow enough because I don't want us to miss even the minute details, how to look for these abnormalities, especially the septate and the bicornuate, which bicornuate and septate is what we see a lot of in the imaging reports these days, based on HSG, based on ultrasound also. They are confused whether it is a septate or a bicornuate, what we have to do. So here I will go again with my basic slide. This is a slide which I have already told how I orient myself. This is going to be the logo of the screen will correspond here to the cranial aspect of the organ that I'm screening, that is the uterus. And this is going to be the caudal aspect. I always take anti-clockwise rotation so that this will follow up the right side of the patient and this will follow up the left side of the patient. So here I'm trying to do a transvaginal sonography. As I've told it in the last class, transvaginal sonography has to begin from the introitus. It is not like just hitting the cervix and only looking at the uterus and coming out. And that is the reason why initially I keep my sector width at a high of 180 degrees so that I want to see the uterus in its entirety. So after taking good consent, even if it's a verbal consent and making her comfortable, I introduce the probe at the introitus, and this is how I do the scan. So I am trying to see the bladder here and the urethra. I'm trying to slowly slide the probe into the vagina, and I'm trying to see here. I'm able to place my probe in the anterior fornix. This is the anterior lip of cervix, the posterior lip of cervix, the endocervical lining in continuity with the endometrial lining. I am taking enough depth so that the uterus is covered in its entirety, covering almost 80% of the screen. I play with my focal zones so that it reaches up to the middle of wherever I'm trying to, the region of interest is being focused. Now, as I come into the mid-sagittal plane, I take my sweeps now after setting my gains and all and adjust the focus. And look, I take my right sagittal sweep onto the right side. This is onto the right sagittal sweep. Then I come back to the middle, and I slowly go towards the left side. So this is my first sagittal sweep, and this sweep is going to tell me whether I am looking out for the borders of the, what I am looking at the borders of the uterus and also the space occupying lesions, if any, in the myometrium. Now I am trying to focus on the transverse plane. I've rotated my probe anti-clockwise, and you are able to see the slit-like endometrial echoes that are seen here. This is where I do the up-down movements. I go slowly towards the cervix. This is a Nabothian cyst that you're going to see. And I go towards the end of the cervix. Then I come up slowly in the transverse sweep upwards. Cephalad. Here I'm trying to see the endometrial lining is getting splayed at the level of fundus. I want to play this again because this transverse sweep, what I'm trying to show you, is one of the most important thing that we need to do in diagnosing a Mullerian anomaly in 2D itself. Most of them will get a clue in your transverse sweep. I'm trying to show you this again so that so that these sweeps are not missed by any of us, so that we want to look at the uterus in its entirety. I go to the fundus, then I go slowly down. You can still appreciate the serosal counter was there even when I lost the fundus. Now I go down slowly towards the cervix and see the Nabothian and up to the lower part of the cervix, still far as I can go. Then I come up slowly and keep looking at the endometrial lining, whether it is maintaining its integrity or whether it is getting split. So this is to show how important is the transverse sweep. So now I will try to show we'll begin with the cases. So I'll try to show in this case where I want you to answer this, what is happening in this case. Here I am trying to show a sagittal sweep. The endometrial lining is closely approaching one cornu and it is going back to the middle in the mid sagittal. Then as I go towards the left, it is closely approaching to the other left cornu. So in my sagittal sweep, I am having a doubt that there is something wrong with this uterine pathology. There is something wrong with this uterus. And if I take a transverse sweep, you are very well appreciating that there are two endometrial echogenic lines that are seen and they are getting bifurcated as I go towards the fundus. But when I go towards the mid corpus and slowly towards the cervix, they are getting unified. So this is to show that this endometrial lining is getting splayed across above at the just below the level of fundus, and I lose the endometrial lining and lastly the borders of the uterus. I want to come back and show you some important points over here. As in this case, if I want to show you, okay, in the sagittal sweep, I will stop here at particular point to show you that, yes, in my proper SAGs, you are able to appreciate the endometrial lining is abruptly stopping far away from the serosal borders. So this is to show that there is a lot of gap here between the endometrial lining and the serosal border. But at the same time, if you look at the serosal border, when the endometrial lining are getting splayed, the serosal borders are maintaining their integrity as convexity here, and you are finding these echoes are not getting disrupted from right to left. That itself is going to tell me that there is some problem with the uterus and likely it is a septate uterus. Now, if I go in the transverse plane, we all are interested in looking at the endometrial lining getting splayed. But for me, this serosal borders is more important. This serosal borders are going to tell, it is trying to tell us that it is maintaining its integrity. Now look here, as I'm coming down up cephalad, you are able to appreciate these serosal borders are maintaining their integrity even when this endometrial linings were getting splayed apart, and even when I lose the endometrial linings echoes, the serosal border echoes were going last. This is to show that I call this as a roof of the house. The roof of the house is well maintained in its integrity when the inside structures are getting splayed. What would have happened if this would have been a bicornuate uterus? I just want to show that. In bicornuate uterus, you would have had a dimple over here, and this echo of the bowel or the omentum would have been in between these two horns. That is to say, the endometrial lining would have been covering their separate serosal borders, and they would have got split. That would have been a bicornuate uterus. So now this case, we all got to know what it is. It's very simple, and we got to know the answer that it is a case of septate uterus. So you are able to appreciate the bifid endometrial linings and the serosal borders. The serosal border is maintaining its integrity, and this is definitely a case of subseptate uterus or a partial septate uterus. So what happens most of the times, we give pictures in the WhatsApp and we try to understand that. Look here. What is mistake in this image is that we are not showing the serosal border in this image. So serosal border indentation or serosal borders bifurcations is not shown here, but definitely it is very easy to say it is we all know it is an septate uterus, but the importance is to show how to look for a serosal borders as well in your 3D image. So now this is how a normal uterus looks, where you need to see that the serosal borders are maintained their integrity and the fundal counter is also maintaining its integrity, as the flat lines playing, or sometimes a small dimple is also okay. And if you are able to appreciate this initial part of the interstitial part of the fallopian tube, then that is a perfect plane that you have taken for the coronal imaging of your of the 3D imaging of a normal uterus. So now I want to show some few examples. All these are falling under subseptate uterus category only. Look here, the serosal borders are maintaining their integrity as a flat line. They may have some convexity sometimes, but they may also have a small indentation over here, and the bifurcated well endometrial linings are seen here. This is all the septa. Why do I say septa? It's still when there is a serosal indentation, we look into this after some time, because the serosal indentation is very less than 1 centimeter, then I will still consider this to be a septate uterus. See, there are a lot of classifications that we have, especially the 3 important classifications, and we all know the 2 important ones, that is the American and the European, that is the ASRM and the ESHRE. ASRM are those people like right from Buttram and Gibbons back in 1988. They told about the classification for the first time of these Mullerian anomalies, and they are the one who gave these nomenclatures like septate, arcuate, bicornuate, didelphys. Still they are very common in our work. ESHRE didn't want to follow that, but still they have used the word septate. They have kept the word septate, but they have used other terminologies like hemiuterus, bicorporeal, bicolis. They try to keep the uterus separate, the cervix separate, and the vagina separate. So we shall try to see what they are up to later. Now, whatever classifications you want to follow, before that, I want to show you some important pic over here. If you look at this and 3D of a subseptate uterus, why am I telling subseptate uterus? Because I'm giving you the answer before. But if somebody wants to make a point, no, look at the angle. The angle is going almost 126 degrees. So definitely it is more than 90 degrees. By ASRM, it is not a septate uterus. That is not the answer over here. See, we are most important. What we are looking at here is the most important line is the serosal borders. If this roof is maintaining its integrity, and even when the wide splaying of the endometrial linings are seen, even if this on today is it at Bangalore and if today it is at Raichur, but still it is in the state of Karnataka, I say it is a case of septate uterus. Don't go with the angles. We all have seen in hysteroscopy and endoscopic surgeries many a times, even if there is wide splaying of the endometrial cavity linings, you can still define this as a septate uterus, because we are not always lucky to have a septate uterus like this with a short, thin, fibrous band. So now we want whatever classifications you want to follow, always try to place yourself in diagrams. See, you try to give a lot of literature there and giving the explanation that what kind of uterus and all you see. My boss doesn't actually look into all this blah blah. He looks into the diagram what we are giving. So I request the sonologist or the radiologist or whoever is making this diagnosis, try to follow one classification. Whatever I follow ESHRE for my own personal reasons, I like it. But at the same time, you try to give a diagram to the surgeon, operating surgeon. He will come to know by what basis that I am trying to treat this patient, whether he is going to do it under office hysteroscopy, whether he is going to use a electrode current source, or whether he can do it by scissors. and whether he has to encounter some problems, like I really need to do a endoscopy, that is laparoscopy, instead of only doing hysteroscopy. So you place yourself in diagrams that will be more picturesque as well as more informative to the surgeon to operate on such cases. So this is a simple case to show. It is a small subseptate uterus that is shown in this picture, where you can see a small fundal indentation here in the hysteroscopic view, a small subseptate uterus. We can definitely resect this by using cold scissors. This is Dr. Jayaprakash Patil's area. It's an old video, but still, these are simple. I don't want to get into the principles and the approaches that we need to do in endoscopy or other routes, because it is not my domain here for the discussion. Just to show what are the different septums that we can see. So you can also correlate a very good subseptate uterus, which is almost reaching the just upper corpus up to the lower corpus. You are able to appreciate a thick septa in between these two horns. So when we have diagnosed it as a case of septate uterus, and based on that, if it is a very thick fibrous band, then definitely we may have to use some energy sources here. We are using the bipolar resectoscope here to cut this septum. So that is how it is. This is a case where I had shown you, this is a case of RPOC on one of the horns on right horn. But this patient had a very thin fibrous septa. So what is the importance of telling you, importance of telling us is that, see, when you know that the fallopian tubes are open, definitely she would have conceived, and that is, but later she had to have an early pregnancy failure, and that turned out to be an RPOC. But that is not, that is one of the clues that her tubes are patent. Now, when you see a small fibrous septa like this, yeah, a small subseptate uterus to even up to extending up to mid corpus, these days we are using office hysteroscopy procedures to cut this. So it all depends, when you try to show these in diagrams that it is a very thin septate, whether I really can do this in office. It depends on the caliber and the acumen of the surgeon. That is how your diagnosis is going to tell the surgeon what you can best achieve with that. So just to show for those, especially for the PGs, if you have not seen an hysteroscope, here is how, and this is in office hysteroscopy. We have not kept the enough pressures over here. This is to see the left ostia, and this is the endometrial cavity, which appears normal with straight flat thing, and this is the cavity anterior borders. This is the posterior borders, and this is the fundus aspect of the uterus, and this is the right ostia. So this is to show how a normal cavity looks in comparison to the previous of the subseptate uteruses that I had shown. So now think we have ended with septate uterus. Now if I ask and post a question, because many of you know these answers, because I've presented this in previous KSOGAs and all in various other webinars, but if you want to answer this, anyone wants to try, what is the answer for this? You can type the answer in the chat box, or you can even speak out by unmuting yourself. This is a case of whatever it is, for fertility issues she had come for HSG. In our unit, we don't do HSG these days, but only when somebody asks for a reference, yes, we do. I did the HSG for this lady, and this is what the HSG got. And this is what we got in HSG film. Yes, I got answer as a unicornuate uterus from one madam over here. Yes. Any more else? Anyone would like to agree with this as a unicornuate uterus? If you can participate a little bit, then I think we can make it more interactive, so that I don't want we to make mistakes in how we're going to diagnose these simple cases. Okay, I got answers as unicornuate. Rest are not trying, not attempting. So, okay, it could be a false passage. Okay, it could be a false passage, but I can define the endometrial horn one side. Okay. Okay, what has happened, I'll tell you. When this lady had come to us, when we did the HSG, this is what the banana-shaped endometrial cavity lining is showing. Definitely, we would have thought in terms of unicornate. That is the most common thing that it strikes our mind. But I will send. Do you think I will send her home with the same report on the paper? Definitely no. That is where a 3D plays a very important role. See, the same case when we did a 3D. Okay, I'm not getting the slide. Sorry, sir, 1 second. Okay. The same case, when I did a 3D, this is what the picture I got. What do you think what would have happened when I did the HSG? The leech Wilkinson cannula, when I introduce here, this is appearing to be a single external os. The septa is actually beginning from the cervical septa, from the septum just below, just after we enter that. The leech Wilkinson cannula has entered in one of the horns of the uterus. And this is what it is trying, it has tried to image only on the right side. So definitely, I had overshoot the septa of the cervix. So that is what has happened. If at all I would have seen two bifid cervixes, then definitely I would have imaged this part separate and this part separate. So when you find HSG of such films, you cannot make a diagnosis of a Mullerian anomaly only based on HSG. So I would try to see, most of us think that 3D has to be in entirety from the corpus to the cervix. No, I will also try to show you what is the importance of doing 3D in different parts. Like for example, in this case, I will be more interested in knowing the cervix. I am trying to show you in this case, I am imaging more on the cervical aspect. When I try to image the cervical aspect, this is what the information I'm getting. This is a walkthrough of the 3D where you have a single external os. And once I go do some walkthroughs, you are able to appreciate one endocervical canal onto the right side and another endocervical canal onto this side. So the septa is actually beginning from here. So definitely I saw one single external os, but my leech Wilkinson cannula entered into one of the horns. So this case, when we operated, most of you have seen this live when we did it, our regional KSOGA conference here at Raichur, and this surgery was relayed from our hospital. And you can appreciate in hysteroscope, there is single external os. So when we introduced the hysteroscope as well, we immediately entered into one of the horns. This is to show that it was a single external os. And once we entered the hysteroscope, we entered into one of the horns of the cervical canal, and with some focus that we got, after we did that, adjusted, and we came back, withdrew slowly, and you are able to appreciate these are the normal crypts. And what is this in between? This is actually the cervical septa. You are able to appreciate that the right endocervical lining, and this is going to be the left endocervical lining. So this septa was actually beginning just in as we advanced from the external os. So well within the cervical canal and up to reaching just near to the external os. So you are able to appreciate that we can appreciate the left side horn of the endometrial cavity. Associated endometritis was seen in this case to show the ostial opening over here onto the left side, and similarly it was seen on the right side. So the other principles, we all know that when you have fertility issues for such lady, we need to resect this we using a hysteroscope. And this was what it was done in the conference, where we had to resect the cavity, that is the septum, and we had to widen the cavity. So now, what is this uterus showing us in comparison to the previous uterus? You are able to appreciate well-defined two bifid cervices here, two external openings definitely. So this is a case of septate uterus, of course. It's not a didelphys. Why am I saying that? You can see the serosal border. It is well maintained. These two endometrial cavities are well seen within the serosal borders they are maintaining their integrity here. They are not split along with the endometrial cavities. So now if I do a 3D of the lower aspect of the cervix, you are able to appreciate two external os and to the endocervical canals as well. There was a small polyp here. I made a diagrammatic representation. And if you look by per speculum examination, you would appreciate that the cervical bifid cervixes would be looking like this with this 3D that we got. You are able to appreciate there is a thick fibrous septa. So this is to show there are two well-defined cervices. It is not a septa like this, a single cervix and a septa in between. No. So what is the importance of showing this? This may be very much evident in a clinical examination, because we physicians will not surpass doing per vaginal examination as well as the per speculum. Do you think it is really needed? Maybe for some radiologists who really want to make a proper diagnosis with the classifications they want to follow, yes, for them it might necessary. Even if you put it as a complete septate uterus, it is our part now to see whether it is a bifid cervix or a septate. I have gone wrong many a times where I have given it as bifid, it would have been a septate. So imaging at the cervix definitely sometimes helps. So what is the importance to show here? Here is when you have a two well-defined bifid cervix, embryologically they carry the good amount of fibers or the stromal tissue along with them. So we need not cut this. There are two schools of thought, but we need not cut this well-defined bifid cervix, the part in between. You can only cut the the corpus. Only the corpus part of the septa can be cut or metroplasty can be done to widen the cavity to give a good fertility outcome. What if we cut this? Yes, there are people who cut this, but definitely they will end up having a stitch. Why? Because cervical incompetence is definitely more known in such cases. So that is why I was trying to stress upon of using your 3D sometimes at the lower part of the cervix. Here you are able to appreciate this is actually the cervix. It is not well imaged for me, but I was not know whether it was a single external os or a bifid external os. You are able to appreciate when I'm trying to move the green line into the cervical canal. Here was the single external os. As I moved into, you are able to appreciate a septa which is beginning just when I entered into the cervical canal. This is a different case to show in our routine 3D. See single os. Then as I move towards, if I use the walkthroughs, this is actually a single external os that is appearing on spur speculum. But when I do my virtual, what you call like hysteroscope, when I use my walkthroughs, you are able to appreciate the septa is beginning in the cervical canal. So the classification differs here, though it is a complete septate uterus. If you want to use as an X-ray classification, this will become as C1, whereas a septate cervix, it is not a bifid cervix. C2 is a bifid cervix. So this is a diagrammatic representation of the same case where you're able to appreciate there is single external os and the cervical, just small cervical common canal, but you have a septa which is the beginning there in the cervical canal itself. Okay, if tomorrow in your OPD, if a lady comes to you showing this picture, don't jump onto diagnosis saying that it is a bicornuate or a septate and all. Please don't make any kind of initial diagnosis, right way diagnosis, straightforward diagnosis based on HSG, because we cannot define the serosal borders in HSG. Definitely HSG is one of those entities will tell us about the patency of the tubes. But for this aspect of Mullerian, whether it is bicornuate or a septate, I would definitely ask you to please do a 3D or even a good 2D itself will tell us, because we shown the importance of 2D. 2D itself will tell you how the serosal borders are maintaining their integrity or not. This is how to show that we need to do a good scan such that in 2D itself we have a hint. 3D, yes, I do agree. Some machines, basic machines, you may not have gone with the TVS volume probe, but definitely in 2D, when you got a hint, when you got a diagnosis, yes, you can ask that it is a septate uterus. Give me proper measurement so that I can have a coronal view and for the measurements. So in this case, what you are appreciating, as I have introduced my probe, I got into the right side of the patient where I could see a very good corpus and the associated cervix along with it. So a good uterine horn and a cervix was seen on the right side. When I started moving my probe onto the left side, I was losing a lot of information, but suddenly I got another uterus there in the left side. So this is clearly showing, I am very sorry, there is some hang in this video, but you are able to appreciate in the transverse planes, there are well-defined bifid two endometrial as well as cervical canals, which are very wide, very much wide apart. And what about the echoes in between? I was trying to show you this echoes of hyperechoic thing or a glistening thing. What you see in between two endometrial cavities will usually be of the converging peritoneal reflections, sometimes the omentum, and very rarely sometimes the bowel. The bowel will not look so hyperechoic, but this is the peritoneal reflection that you have between these two horns. This is the right side horn and this is the left side horn. So this is to show in 2D itself that there are two well-defined, well apart bifid cavities, that is bicorporeal entities. And even when I went towards the lower part of the cervix, they were getting bifurcated and two well-defined cervices was seen. This is actually a case of didelphys. So there is some literature differences between bicorporeal and bicolis. That is also what the X-ray says. But by didelphys, they usually don't communicate even till the lower part of the cervix, very rarely at the lower part of the cervix. Whereas bicorporeal, bicolis, they might get communicated at the level of the internal os up to even the cervix. So yes, if you want to use it as bicorporeal, bicolis would be the right terminology. Or else, if you want to follow ASRM with these two, it is going to be uh, didelphys uterus. So you can see here the vaginal view. You are able to appreciate well-defined bifid cervix, two circles there with a thick fibrous band. So now what is this telling me in TVS? When I got two well-defined cervical canals, I need, being a clinician, I should definitely give my boss whether there is a vaginal septa also or not. What is happening is that me being a clinician, I will depend a lot on my clinical examination from my colleagues or from myself, where I should go and see, because the same case had a longitudinal vaginal septa as well. This is a common entity where you have a well-defined bifid cavities, the uterus and the cervices, and along with that you have another Mullerian aspect, the vaginal septa. That is one of the reason I like X-ray, because they keep the corpus separate, they keep the cervix separate, and also the vaginal part. So here they have U as the uterus, C as the cervix, and V as the vagina. And based on that, you can, sometimes you don't have the septa in the vagina as well. Your diagnosis will become V0, or else it will be V2 or V1 based on that. So this is a case of didelphys uterus. See, sometimes what would have happened if this was a young girl who would have presented where I have not done a TVS, what with severe dysmenorrhea. This is a very common entity, not a common entity, but not to be missed entity, where you have hematometra in one of the uterine corpus, maybe into the hematocorpus as well, but it would have been a partial septa obstructing this part or that part, and you would have had associated endometriosis component also. And if there is absence of kidney on one side, then the same entity becomes as a ovira, that is obstructive hemivagina with ipsilateral renal agenesis with hematometra within here. So they will usually present in early life with severe dysmenorrhea. So that is one of the reason. Now, when you have patent vaginal canals on both side, why couldn't I diagnose this in my TVS? What would have happened? When I introduced my probe, I would try to show that in the pen over here. If I would have, sorry, if I would have introduced my probe over here, my probe would have gone into one of the vaginal cavities, because this is a collapsing organ. So this septa would have collapsed towards one of the walls, and definitely I would not be able to see this as the vaginal septa. Maybe if I use a lot of gel on both, if I have that intuition that is going to be a vaginal septa, then you have to put a lot of gel on either sides, then you can image this. For us, it is not important, I feel, because you have a speculum in your hand. Go and observe this before putting your vaginal part as the diagnosis. For the completion of your diagnosis, put the cervical speculum and try try to know what's happening. So this is the same case when you do the laparoscopy. You are able to appreciate it's a peritoneal fold, that reflection that you see most of the times, and you are able to appreciate the left uterine horn with a corresponding fallopian tube and the ovary, and also the right uterine horn. They are well wide separated. And what is the role here while doing this endoscopy for them? If they are for infertility, just look into the how the structures are related and look for the patency of the tubes, and that is what it is. At present consensus, there is no role for any unification surgeries, provided if the cavities are good, you need not worry. Actually, to tell you, we have got a very recent case also, where this a lady has got pregnancy in both the horns. She has undergone cesareans on both. First it was on the right, next it was on the left. And some cases they usually don't come with any complaints. That is one of the reasons. It is the incidence we cannot really tell of didelphys, because many of them will not have any complaints, even for that matter for the fertility issues. The uterus which has a lot of problems is the septate uterus. The first cause is septate, the second is septate, the third is septate. They have fertility issues in all aspects, right from the implantation, sometimes even for the midterm losses. So you will have all those, but sometimes even a small good septa with good vascularity, even that will not cause any problem. So of all the Mullerian anomalies, it is the septate uterus which is causing most of the problems. That is why I took it so in depth. And in the next case, if you are able to appreciate two well-defined bifid endometrial cavities are getting splayed apart, and they are not getting, though they are seen unified here at the cervix. What is difference between the previous images and this image? I want to show it again. You can appreciate it better. The serosal borders are going along with these endometrial linings. They are getting very widely splayed, and the echoes of these peritoneal reflections are trying to encroach in between these two horns. So this is to show this is a case of bicornuate uterus, and the lower part of the cervix, though I have tried to show it, it is a it is a single. You want to say it is a unicollis, bicorporeal unicollis. So this is how a diagrammatic representation with 3D will try to show you that it is a bicorporeal unicollis uterus. Even let me tell you, the bicornuate entity which we see are more common on the papers rather than in the real life. See, we are most of the times we are missing the septate uterus, and we are trying to tell this septate, which is looking as septate, as bicornuate. So that is what we are trying to see. In the last few years of my practice under Sir, hardly in a year we see some 3 or 4 bicornuate, honestly, and the rest all will be septa is very common in a week 1 or 2. So you are okay. I want an answer from everybody. What you are trying to see this. I will play this clip twice. I want an answer in the chat box. This is the transverse sweep. As I'm going down, these are the endometrial cavity linings, and they're getting unified lower. I have given you the hint. Again, I will try to show you. They are getting wide apart. And what is happening to the serosal borders here? I want an answer from some of you to please chat, because this is an interesting case, because I'm not confusing you people putting the classifications, remembering U2A, U2B. No, I'm just trying to show you what exactly you are seeing in 2D and what is your mind is actually looking into. Somebody answered 3D is needed. Okay, I do know it's 3D is needed, but I can make some diagnosis in 2D itself. At least we can definitely make it's bicorporeal with septum. Bicorporeal, it is septate. I'm very happy that majority of you are trying to answer this. It's a complete septate. Thank you for taking this small questionnaire that I am trying to post you. I'm very happy that one of the sirs have really, I think he's a master. I have seen sir in many of the webinars. So he has rightly answered it as a bicorporeal septate. I'll try to explain this. See, in my transverse sweep, this is at the level of fundus. Two well-defined uterine horns are getting separate. When I'm trying to go back, you are able to appreciate there is serosal continuity first and then the endometrial continuity. I'll try to show that when I come back. See here, the endometrial cavities have lost they got bifurcated, but the serosal borders were maintaining their integrity. I'll try to play this again and again, because we'll lose this here. You are able to appreciate it is getting unified here, but still the endometrial linings were getting separated. So this entity is actually a clubbed entity. It is a clubbed entity of a bicorporeal septum entity. You are able to appreciate here at the level of extreme fundus level, they are getting separated. But when they are coming back, when I'm trying to show this, they are getting, the serosa is getting unified first here, and the endometrial cavity linings in the lower part. So this is a very good answer by one of the sirs who has posted. Thank you, sir. This is a case of clubbed entity of a bicorporeal septate entity. You are able to appreciate at the level of fundus, they were getting widely apart. This was the serosal indentation. And you also saw before there was the myometrial or the tissue or the echoes that were seen just below that, where the serosal borders were maintaining their integrity. That is actually the septal part. So this fundal indentation, this serosal indentation is actually more than 1 centimeter. And also this indentation is actually more than 150%. I'll try to explain that later. So this is having a clubbed entity of a septum as well as a seros of the bicorporeal entity also. Why is this important? Why is this important? See, I'll try to show you one more case. Why this is important? I have not measured here, just to show if in case I want to use the pen, and see, it is the serosa. This is imaginary line, and if you draw a in between the serosal depth, okay, this line which is the showing the serosal depth, if it is more than 1 centimeter, you can call this as a bicorporeal entity. And what about this? This is actually the septa. So what I'm trying to tell my surgeon is, you have a septate entity, you can definitely cut to some extent, but you cannot overshoot, so that you are not going to enter into the myometrial planes, or you are not going to enter into just cross the serosa and cause damage, or not to overshoot. So this is to show that you have a bicorporeal septate entity. You are guiding the surgeon that definitely you can make some correction to better outcome by increasing the cavity, but at the same time, our imaging is helping them to tell that you should not overshoot. So this is the case of clubbed entity of bicorporeal septate entity. So what about this case? I had shown you in the the initial slide, where I tried to show you 3 types of uteruses. Here, look at this. This serosal indentation is very small, almost less than not even half of the width of the myometrial wall. So it is very less than 1 centimeter, to be in very simple words. If this is less than 1 centimeter, you can still take this as a septate entity. This is a widely or a broad-based septum. Okay, and we have observed this in endoscopy. When you try cutting these fibers, usually they would have pulled on both sides, and if you try cutting this septum, and they will get released, and this will become more flat. That is observed in our endoscopic surgeries. That is to be shown. Now tomorrow, when you start doing your scans in the OPDRs, in your scan rooms, and you are able to appreciate that there is bifurcation of the endometrial cavity linings at the level of fundus. Now, what is this? Do I really need a 3D? Yes, you will do a 3D, and 3D is giving you this definition. So what do I want to paste this? Any answers for this? What do you want to paste this? Okay, I will put it one more. Why am I not getting the others? Okay, what do you think these uteruses are? This is a subseptate uterus. Okay. Subseptate, arcuate. Yes, thanks. This is just to make you get connected with the class. Thanks for your responses. But let me tell you, we'll come to that later. I just want to introduce you. Why this is... Okay, the confusion comes more when we put a diagram like this, whether it is going to be a normal uterus or whether it's going to be a subseptate entity. The previous case had less of fundal indentation. I will try to show you in the importance of this picture. I will try to make it simplified, but if you really want to go by classifications and the calculations that we have, that is, they are quantified. Septa uterus is the most common and the problematic uterus, we all know. And how do you going to quantify that? On what basis you are going to tell it as septate? So we all know, I just want to bring out the pen over here. We all know about ASRM. Now ASRM has got updated in 2021. You also know about ESHRE. ESHRE, yes, it was in 2013. From that to 2016, they got updated, and now we are waiting for further updates from ESHRE. We have got a newer one. Some of you would have heard about this. That is the Kuhn criteria. That is congenital uterine malformations by experts, by someone called Ludwin and his group. In 2018, they have done extensive work on septate as well as T-shaped. They are the first people to quantify a T-shaped uterus better than anyone else. Though ESHRE brought out T-shaped as a morphological dysmorphic uterus, but these are the people who brought it about the quantification of that. ASRM is still not yet defined the dysmorphic or the T-shaped uterus. Okay. Now what has happened in 2021? I'll make a small correction over here. The ASRM people made this as 1 centimeter depth. What I'm trying to show you, this white thing is the endometrial cavity lining. This is the wall. This is the myometrial wall. And what is this? This is the serosa. This is the serosa, fundal serosa. This is a imaginary line joining the two cornal ends of the endometrial, bifurcated endometrial linings. So, and what they are trying to tell you is that this line from this imaginary line to the deepest indentation pocket is the indentation depth ID, whereas this from this line to the topmost serosal border will become the wall thickness. This is going to be the wall thickness. So now what they are trying to tell you, ASRM people, if this line from the imaginary line between these two is, if it is more than 1 centimeter depth, then it is going to be septate entity. It was 1.5 previously. Now they have rectified. They have put it as 1 centimeter. They have fixed it as 1 centimeter. But the angle they have not changed from 2016 to 2021. They have kept it still at 90 degree. So ASRM, if you look at my previous image, it was 126 degree and now it is only 90. No, I cannot classify totally as. Sir, 1 second, sir. I'm very sorry. Hello, sir. Yeah. Sir, sorry, sir. No, sir. For class, there is sir. No, sorry, sir. Sir, sorry, sir. Okay, sorry, I'm very sorry for that. Now 90 degrees what they're trying to make it. So they have not rectified it. Okay, we are very clear about it now. Now, if I come to the HRA classification, please look here. HRA has not made a fixed entity like 1 centimeter or 5 mm or nothing like that. They want to make it as a proportion. For example, this is the uterus and this is the indentation depth and this is the wall thickness. If any problem from my side, I want any one of you can speak and let me know if it is slow or if you're not understanding or if it is this, there is, if the markings are not seen, please let us know, sir, please. Okay. Okay. What they're trying to tell you is, if the indentation depth is more than 50 percentile of the wall thickness, then it is a case of septate uterus. What do you mean by that? If the wall thickness is supposed to be 1 centimeter, and if the indentation depth is even 6 mm, this is going to be a septate entity. It need not be 1 centimeter. So you got the point right. It is only based on proportions. So you cannot classify everyone saying that 1 centimeter depth has to be a uniform criteria, because in India, you have short uteruses, even in among families or even regions, you have different varied populations of different height. So the uterus size also will be different. They are trying to put it in proportions. Okay, now in 2018, they want to rectify all these mistakes what the ASRM and the HRA was giving, and the CUME people came up with a better diagnosis on septate, where they kept it as 1 centimeter, only not at 1 centimeter. They also tried to classify on the proportions of the wall thickness and indentation depth, and also on the angle. I will try to show that in the next slide. Before that, you can look here in the topmost 3 images that has been shown over here. These images, what they are trying to tell you, they have taken this part, they have cut this part and they have posted up. What is happening here? This is the serosal lining. Now there is a serosal lining indentation. If it is more than 1 centimeter, then you take it as bicorporeal. Or if it is less than 1 centimeter, it still falls under septate entity. Even the ASRM as well as the CUME are keeping this as 1 centimeter. What about the HRA? They have told if the wall thickness is 1 centimeter, this indentation has to be less than 5 mm, then only it will be septate. If it is more than 5 mm, this will become bicorporeal. That means to say the serosal indentation has to be more than 50 percentile of the wall thickness to call it as bicorporeal entity. I hope I am clear with this. So why am I trying to post all this? Because these are the 3 major consensus that we have. Till today, we don't have a uniform consensus for these Mullerian classifications, which has to be followed universally or across the globe. You can follow what you want, but you follow one thing and try to place the same classification in your paper and leave it to the concise of the surgeon whether to operate or not operate. So now, I want to show the depth of CUME classification. This is what they gave. I already told you they have kept the depth at 1 centimeter. Yes, that is one point. They also try to rectify the angle here. Look at the angle. The angle they have taken up to 140 degree. Very recently, I had a very nice uterus where it was so wide, broad base, it was almost reaching 136 degree, but the fundus was here. Though you have less part to cut, but definitely that falls under septate entity. So it is less than 130 degrees. So then what about this? What about this? The first diagram, they are trying to again tell the indentation. This is the indentation depth and this is the wall thickness. They have made proportions for that. If the indentation depth is more than 110 percentile of the wall thickness, that is, if this is 1 centimeter, if the wall thickness is 1 centimeter, indentation depth has to be at least more than 11 mm. Or if, for example, if it is 5 mm, it definitely it has to be 6 mm. So that is what they are trying to tell you. So we don't know what they are trying to claim is Eschrey is actually over-diagnosing septate entity, whereas ASRM was under-diagnosing the septate entity. Cume tried to make some rectifications, but we still don't know whether they are the right people or not. A lot of research is still going on. Yes, till today we have these three and you can follow one of them. You are not wrong, but you have to place based on what classifications you are telling it as a septate entity. For that, 3D is essential and also the right proper coronal plane is important. We shall try to see that. See, many of you took that challenge as saying it as an arcuate, but I'll try to tell you arcuate is now normal. So ASRM was the people, they given the nomenclature as arcuate septate. I told you. Now they are telling there is nothing like arcuate. It is just normal. So that was the take home. I wanted to tell you small indentation need not you classify this as septate because I am trying to put the same question that I had posted. Look here, the 3 mm is the 3 mm is this, whereas this is 7 mm. So if it is even by Eschrey, it is less than 50th percentile. It is definitely not a septate or a arcuate. Don't arcuate you can use, but it has to be slowly removed out. That is what they are trying to tell you. Okay. Now, how many of you want to take this as a normal uterus? I will stop with this with few. From I want to stop with this small because we'll take up interesting cases next sessions. How many of you think this is going to be a normal? This is a 3D I got of a particular uterus. Now I'm putting this across the WhatsApp group to one of the groups and I have asked you whether this is a normal uterus which I have got. See, there are some pitfalls in 3D. That is the importance I'm trying to show you. This uterus, when I actually did a in sagittal plane, in wrong plane, I was losing informations in the coronal lens. These coronal lens are important actually. I will try to show that in the next slide. Look here, this slide is trying to show me the same uterus. The numbers are same, the same uterus. What is the difference that you are trying to see? The coronal lens were not properly imaged in 3D and you are able to appreciate there is definite small bifurcation. It may not follow that septate entity by ASRM or Q, but we have done incomplete, we have got incomplete information by when we are losing the information at the level of cornu. So that is how we need to play with your 3D. 3D is not always static that I want to bring it out. 3D, you may have to take a very good proper plane. If you are not getting it in one plane, you may have to use your x-axis apart from the z-axis, which is most commonly used. You have to use the x-axis or walkthroughs to understand. See, you are losing information in this part. Okay, now when I took this same imaging in 2D, look here, you are able to appreciate in 2D, there is definite bifurcation of the endometrial cavity linings. When I take the transverse sweep, you are able to appreciate there is bifurcation of the endometrial linings. So what has happened is, see in sagittal, sometimes when the uterus has got deviated or if you don't follow proper the view line, then if you don't have enough depths, then definitely we may go wrong. Because here you know that it is the separation is seen only in the upper corpus, not in the lower corpus. So I am not interested in the lower corpus. I take my 3D in the transverse view so that I am going to look at the bifurcation of the endometrial cavities properly. That is going to give me good quantification with respect to the measurements that I want to follow. And that if you try to do it, see, you can use OmniView. You can use the conventional 3D that can be discussed later when we take up any class on how to do a 3D and all. But this is to show that if you have not taken a proper 3D, definitely we will lose information. See, this uterus is showing definite indentation. If I actually followed the X-ray classification, this is showing to be a partial septate uterus. So I just want to emphasize that just a normal looking uterus in 3D may not be always the same. I always want you to correlate that with 2D, because my 2D was giving a hint there is bifurcation, and my proper 3D is going to tell me what indentation depth it's going to have. Okay. Now, and some last slide I want to, this is the normal uterus. When you try to show the normal uterus, if you are able to get the good coronal planes, you are able to appreciate the interstitial part of the endometrial lining, fallopian tube, then it is a good 3D. Okay. And obvious ones, you may not get into that plane, but you know it is a septate. Yes, it has needs corrections. You can definitely go for it. So what is this now? This is the last slide I want to share because it's time up for 1 hour. I don't want to take more time. So what is the answer for this? Simple. I'll play this again. It's getting played, I think. So you have pregnancy in one horn. So it's a very common situation, now this lady is, it is no, there, you are able to appreciate there is pregnancy in one horn. And at the lower, this is another horn, there is a left horn, and they are getting communicated at the lower part at the level of isthmus, and there is single cervix. And what about the serosa over here? So I want to emphasize here, we have often seen majority of us will try to post after cesareans when we exteriorize the uterus and tell, okay, this is a bicornuate uterus, this baby was on this horn. And I don't think that is actually needed. Why? Because when the woman got pregnancy, and what more you want? She was not complaining, that uterus has not complained her for any reason. First thing. Next thing is that we are actually wrong in diagnosing a Mullerian anomaly in pregnancy. What will happen? I'll tell you. Maybe some of you think that there is indentation of this serosal lining. Why this is happening is that, see, if you have a uterus like this, or even if a uterus which is having a septate entity, if the pregnancy is in one horn, this will grow eventually. This will grow eventually. And what will happen? This looks as an indentation. Sometimes this will grow eventually, getting into the myometrial planes, and this serosal border, this part will be slow in its progression or the growth. And we feel that we have done an surgery on the bicornuate entity. So I request, don't make any Mullerian classifications in pregnancy, provided you have a smaller, okay, here also I can definitely make it as a septate based on the knowledge that we are having now. But if it crosses more than 12 weeks or 13 weeks, definitely the fetus will overgrow on one part, and you will not find the other, you will find the other part being regressed back. And when you do cesareans, we feel that we have done it in a bicornuate uterus. So there is no consensus yet to diagnose a case of Mullerian anomaly in pregnancy. Maybe you have to always do that and classify that in an interval period only, not in pregnancy. So I will be taking some interesting cases of other things and also the classification maybe in the next class. With this, I want to end. If any queries, I will definitely try to answer today. If not, I am not knowing. I want seniors to answer this. And if then otherwise, I'll prepare myself for the next class with the questions, answers that has to be answered. Thank you, sir. Thank you for giving me this opportunity, sir.
Dr. Manjunath here from Belgaum. Thank you, Raju sir, for a very wonderful session. I think your 3D images are really mesmerizing. One should inspire from your 3D imaging. I think you have completed a majority of the topics and practicality. If any questions, he'll be happy to take. Yes.
Thank you, Manjunath sir.
Dr. Raju.
Sir, namaste, sir.
Namaste. Good evening.
Sir, good evening.
I think it's an amazing presentation. Actually, all these 3D pictures I'm seeing as though it is in the movie, It is so nicely, collected all, and excellent demonstration. I think audience, even though you took so much time, there are more than 60 audience, and it's an excellent demonstration. Some of the cases what we have seen, we used to diagnose in a that way, but you cleared it, how to make it Bicolis separate then the complete septum. It's
Yes.
amazing. But whether only question is when there's a complete septum is there, do you resect completely, because it can lead to the incompetent cervix.
Yes, sir.
So whether we should leave it alone.
Yes,
That's
sir.
my question.
Yeah, definitely, sir. I told that in one point there are two schools of thought. I have come across literature, sir. But if you are going to definitely resect the cervical septa, we always feel that stitch is needed. And
Sir, good evening.
sir,
Raju,
JP sir
good
is here.
evening.
Namaste, sir. Namaste, sir.
Sir, Bella sir, I'll answer this question.
Yes, sir. Please, sir.
Sir, see, you must have seen Bella sir, there is, as Raju said, there are two schools of thoughts. Number one is that you put a Foley catheter in one horn and then resect only the middle part. That is only the uterine part, that is a carpus part, and not touching the cervical part. And so that, what happens, you have a,
You try to maintain the integrity of the cervix, so
cervix,
that the
and then,
incompetence won't occur.
yes. So
But I have
eventually,
resected one case I resected completely, and I
yeah,
put an insert class, and patient went till term and she had a nice
that's what,
baby.
sir. Okay, sir.
I mean,
So
this
that's
is
what.
my experience.
Sir, listen, sir. See, what is happening is now with our, as I and Raju work together, we have a good series of patients where we can tell that, okay, this patient requires circlage or this patient doesn't require circlage. I'll tell you cases where it requires definite circlage, even septum cases. See, where the fundus is very broad, okay, and there is a septum which has come almost, as Raju said, more than 1, 2, 3 centimeters, but the fundus being broad, usually they go for funneling of the cervix or anything like that. Even T-shaped uteri, not all T-shaped go, but then they are prone. Then these septate, complete septate, 100% you need to put a circlage. Initially, I tried doing that, maintaining the integrity of the cervix, but it is technically very challenging, and sometimes you may end up actually going into the posterior anterior wall and perforating. So I have stopped that. What I do is, when there is a complete septum, I don't try to maintain the cervical integrity, just cut it from cervix up to the fundus, make it one. Then you explain the patient. Once you have finished the NT scan, we do a Shirodkar. This is our standard practice with a fantastic results. So we
Yes.
have done a lot of cases. Unfortunately, we don't have that documentation and presentation and all that. But Mullerian, we have a very good series, and whenever there is suspicious of funneling or anything, Mullerian anomaly, we follow them very rigorously during pregnancy. Raju does cervical monitoring from 12 weeks, 16 weeks, 20 weeks. Whenever we feel there is a funneling, we go for circlage. But this complete septate and broad-based, we put it prophylactically. This is
I
the
have
bottom
a
line.
JP. Before that, I have a suggestion. You must be having case records of these.
Yes, sir.
You
Yes,
have
sir.
electronic. you have electronic data.
Maybe, sir, yes, but yes.
Well, why I'm saying is, we have given you one nice PG there, Sagerin. You just
Yes,
ask
sir.
her to do that, and it is a nice collection. Please publish it.
Yes, sir. We
Please
should do that.
publish. Otherwise, I will come and collect the data and come and publish this article.
Yes, sir. We will try to do it, sir. Thank you.
Thank you, sir.
Thank you.
I am Dr. Bhakta. I think Raju, wonderful presentation
Sir, namaste. Thank
and
you, sir.
excellent your video and that 3D pictures and makes things more clear with whatever explanation. I think wonderful. Keep it up.
Sir, thank you so much, sir. Thank you, sir. Thanks for joining, sir. Thank you so much, sir. Okay, if no questions.
Excellent, Raju. It was lovely. I
Ma'am,
hope.
thank you so much, ma'am. Thank you, ma'am. Thank you, Jyotika, ma'am. Thank you so much, ma'am.
I think, Raju sir, if no questions, we'll end the session.
Yes, sir.
It was nice listening to your talk.
Thanks,
Okay.
everyone. Thank you for joining. Maybe in the next class, instead of obstetrics, we will take up the second part of Mullerian, where we have interesting cases to show. I don't want you to miss those anomalies, like, whether you have vacuum or unicornate with rudimentary horn and all, some rare cases as well. Thank you for joining. Thanks, everyone. Thank you, Durga Das sir. Thank you, Shobha ma'am. Thank you, Billat sir.
Thank you, Raju. Wonderful.
Sir, thank you, sir. Thank you, sir. Thank you, JP sir. Thanks for joining, sir. Arun, if you are there, we can end the. Arun.